By the time we knew the doctor was lying, we couldn't escape, and the patient was near death. The first time I heard Dr. Keller say she's stable, I was standing 6 feet from a dead monitor. Not dying, not crashing, dead. Black screen, no waveform, no pulse ox trace. The portable monitor had been unplugged, rolled halfway into the hall, and left there like someone had tried to get it out of the room fast and then changed their mind. Inside room 412, the patient was making this wet, shallow sound with every breath, and Keller was saying it again, calm as ever, like he was reading from a script. She's stable, no transfer, no family call yet. I looked at the patient and then at the chart on the workstation outside the room. The vitals he'd just entered were impossible. Blood pressure normal, oxygen 96, responsive to voice. She wasn't responsive to anything. I said, "Doctor, these aren't hers." He turned to me so slowly it made my skin go cold. "Are you questioning my assessment?" he said. Then the fire doors slammed shut at both ends of the unit. Not an alarm, not smoke, just the magnetic locks engaging with that hard metallic clack that meant our floor was sealed, badge access restricted, stairwell doors held closed until security cleared whatever had triggered it. I remember looking through the weird wired glass at the far end of the hall and seeing one of the transport aides hit the bar on the stairwell door twice, then turn back toward us. That was the moment I knew two things. The doctor was lying, and whatever was happening on our floor, we were now locked inside it with a patient who was already too close to death. My name's Erin. I was a night charge nurse on the step-down unit at Northview Medical Center for 6 years, and I have replayed that shift enough times to memorize where every cart was parked and which overhead light outside 412 had started flickering that week. I still don't know if any of us could have stopped what happened. I only know we proved he was lying too late for it to matter. It was a Thursday night, end of the month, which meant the hospital was full and everyone was under pressure. Step down had become overflow for half the building. Patients who should have been in ICU were waiting on beds. Patients who have gone home were still sitting on discharge holds because transport was backed up, or family hadn't answered, or insurance was playing games or something. We were short 2 nurses and 1 respiratory therapist. We always seemed to be short there. Security was dealing with some kind of incident in the ER, which mattered later. Room 412 was a 58-year-old woman named Denise Harrow. Post-op complication from what was supposed to be a routine abdominal procedure done 2 days before. Internal infection, borderline sepsis, blood pressure running soft all evening, breathing worse after 9. She should have gone to the ICU before midnight. Everyone on the floor knew it. Keller was the attending doctor covering surgical complications that night. He was polished, careful, and hard to pin down. The kind of doctor who never raised his voice because he didn't need to. He could make you feel insubordinate by blinking at you. At 11:07 p.m., Denise's oxygen started dropping into the mid-80s, even on supplemental oxygen. Her skin had that gray, damp look that makes every nurse on Earth move faster. My primary nurse on that side, Tasha, called respiratory. I called Keller. He came up after about 15 minutes, glanced at Denise for maybe 10 seconds, listened to her chest, and said that she was anxious and tiring herself out. "She needs ICU," I said. He said she needs to settle down. Then he put in orders for a mild sedative and charted that she was improving. That part bothered me immediately, but the doctors write bad notes all the time. Sloppy, optimistic, self-protective. You learn to work around it. What made this different was how deliberate it felt. He wasn't describing a patient generously. He was describing a different patient. By midnight, Denise's urine output had dropped off. Her abdomen was more distended. She wasn't answering questions clearly. Tasha whispered to me outside the room, "She's circling." I went back to the chart. Keller had entered a note at 12:03 saying the patient was alert, perfusing well and not respiratory or in distress. He'd also documented that he had discussed ICU transfer with nursing and that the nursing staff agreed, on continued monitoring until step down was appropriate. That last line made me so angry I actually laughed. I took a screenshot on my phone. That was the first thing I did right. The second thing I did was call the nursing supervisor and ask her to come up. She never made it to the floor, because at 12:11 the doors locked. Overhead, we got a plain security tone and a clipped announcement. Restricted access in effect for towers 3 and 4. Remain on your unit pending clearance. Everyone in healthcare gets used to weird operational language. You hear words like incident, restriction, process delay, temp hold. They flatten everything. They make terrible things sound manageable. But when those doors locked, our unit changed instantly. You could feel it. Half the staff went quiet. The patients who were awake started hitting call buttons because they heard the doors and sensed the shift in us. I called the operator for clarification, but of course there was a busy signal. I called security and it kept ringing. Then Denise's telemetry dropped off the central monitor. Not because she'd coded, but because someone had disconnected her. Tasha yelled from inside 412, "Hey, her leads are off. Who did this?" I ran in. The leads were gone. The pulse ox was removed. The IV pump was paused. Not beeping. Paused. You have to physically touch the pump and silence the alert chain to get it that quiet. Denise was still breathing, but barely. And there was a fresh crease in the sheet where something bulky had been pulled away from the bed. "Keller was in here," Tasha said. "He came back while you were on the phone." I didn't even ask why she hadn't stopped him. There are hierarchies in hospitals that people outside don't understand. A doctor with authority can move through a room like he owns reality, and if the rest of us are split between 6 alarms and 3 families in a locked unit, a lot can happen in under a minute. I grabbed the bag valve mask and called a rapid response. No answer. Not a "they're coming," not a delay, nothing. The call showed us placed on the unit phone, but there was no return page, no team overhead, nothing. That was the third thing, the one that made this feel less like one bad doctor and more like the floor itself had gone blind. I used my personal cell to call the ICU charge desk directly, and they answered. I told them I needed a bed and a rapid team now. The ICU nurse said, "We can't come down. Tower access is frozen. Security has all vertical movement locked pending clearance." "We have a patient crashing," I said. She said, "Then intubate and hold them there." As if we had an airway team standing in the supply closet to do that. Keller reappeared while Tasha and I were trying to stabilize Denise manually. He stood in the doorway in full PPE, face shield up, expression flat. "What exactly are you doing?" he said. "Saving her," I said. He stepped inside and looked at Denise as if she were a mild inconvenience. She was DNR, comfort focused. We discussed this. "No, we didn't," I said. He looked at me, then at Tasha. "The update is in the chart," he said. But it wasn't. I checked immediately. A new scanned document had appeared in media files at 12:14, an advanced directive. Comfort measures only. Electronic signature from a family representative. Except Denise's husband had been dead for 3 years. Her daughter lived in Arizona and hadn't arrived yet. I knew that because I had spoken to her myself at 9:40 and told her to get on the first flight she could find. "This is fake," I said. Keller didn't even deny it. He just said, "You should be careful about using that word." That was when one of the unit clerks, Mateo, came around the corner holding a paper chart packet. "Aaron," he said too loudly, "why are there 2 labels for 412? We all turned. Hospitals still run on a messy mix of electronic records and printed garbage. Downtime forms, wristband backups, medication labels, transfer sheets. Mateo had found a duplicate packet printed from admissions with Denise's name, room number, and medical record number, but the code status line was different. Full code, ICU consult pending, blood cultures critical. The printed timestamp was from 11:58 p.m. The chart Keller had been documenting in had been altered after that. I walked right past him and took the packet from Mateo's hand. Keller said, "That's not current." I said, "It is if it's true." For the first time all night, he looked rattled, not scared, annoyed that the story had slipped. I called house admin from my cell, then the ICU fellow directly, then risk management's after hours line. I left messages for everyone. Tasha was squeezing breaths into Denise and crying while she did it. Across the hall, a confused patient kept yelling, "Why are the doors shut?" Then the lights dipped. Only for a second, but enough to kick half the pumps into battery alarm and reboot one of the hallway workstations. Somewhere farther down the unit, a patient started screaming. What we learned later was that security had locked tower movement because a man in visitor clothing had been seen entering a staff stairwell and then vanishing on camera between floors. They thought he might be armed. That was the official explanation. It didn't help us at all in the moment. All it meant was that no one was coming, not fast enough. I pulled Denise's chart history and finally saw it. A cluster of late edits, overrides, and access from Keller's credentials, starting right after the CT results had posted. Her scan showed a probable bowel leak and rapid fluid collection. Surgical failure, bad enough on its own. Worse, because he'd been the one in the OR. That's when the shape of it all came together. He wasn't just downplaying a decline. He was trying to buy time. Time to alter the record, change the code status, and make it look like her death had been expected and managed instead of missed and escalating under his care. I said it out loud. He's covering the surgery. Tasha stared at me over the mask. Keller said very softly, "You are far outside your lane." Maybe I was. I don't care anymore. I told Mateo to print the full audit trail. He ran back for the office. Keller followed him. He stepped in front of the door. For a second, I really thought he might shove me. That's how stripped down everything had become. No bedside manner, no titles, no pretense. Just a man trying to get to a printer before the rest of us saw what he'd changed. Instead, he leaned in and said, "Do you understand what happens to this hospital if there's a surgical sentinel event during a tower lockdown? Do you understand what headlines do?" I remember thinking how insane that was. Denise Harrow was dying 10 feet away and he was talking about headlines. "Move," I said, and he didn't. Then, from inside 412, Tasha screamed my name. Denise had gone into arrest. Everything after that happened the way bad codes do when the room is full of the wrong people and missing the right ones. We started compressions. I overrode the med drawer. Someone dragged the crash cart in sideways because the hall was jammed with sealed linen bins and abandoned equipment. Respiratory still wasn't there. The rapid team still wasn't there. Keller kept saying, "Stop, she's comfort care now, stop." I shouted back, "She was never in comfort care." He actually reached for the chart pack into my hand while we were coding her. I still hate him for that more than anything else. Mateo got the audit trail printed. He slapped it on the counter by the sink. I only saw pieces then, but enough to understand. Code status modification entered from Keller's login without the required witness workflow. Progress note edited twice after signature. Vital signs manually entered from an unverified source manual. ICU consult discontinued and re-entered as deferred. It was all proof, real proof. By the time we had it, Denise had been pulseless for 9 minutes. The rapid team finally got access to the unit at 12:31. ICU fellow, respiratory, 2 security officers. They came in hot and saw the scene, saw the papers in my hands, saw Keller standing back from the bed like he was already separating himself from it. We got a rhythm back once, briefly, enough to move her eyes under the lids, enough to make me think, stupidly, maybe. Then we lost it again. She was pronounced at 12:47 a.m. The tower restriction was lifted 13 minutes later. That's the part that makes people furious when I tell them this story. Not just that the patient died, that the trap was temporary, that if the timing had shifted 20 minutes one way or the other, maybe ICU gets her sooner, maybe risk gets involved sooner, maybe somebody with more rank than me walks in before Keller has room to rewrite the truth. Afterwards, security detained him for about an hour, not because of Denise, but because his badge had been used to open a physician records office. He had no reason to be in during the lockdown. He claimed he was trying to print forms. There was no criminal charge that night. Hospitals protect themselves first. They call it preserving process. But the audit logs were real. My screenshot was real. Mateo's duplicate packet was real. Tasha's statement was real. The daughter arrived at 4 a.m., and by then nobody on the floor was speaking above a murmur. Keller resigned 3 weeks later, before the internal review had even finished. Officially, Denise died from post-operative septic shock complicated by delayed recognition of surgical leak. The report used 10 pages to say what all of us knew by 12:20. He lied about her condition, changed her chart, and tried to turn an active decline into an expected death. People ask me why I still say that we were trapped. They hear that word and think I'm being dramatic, but I'm not. For 40 minutes, the doors were sealed. Response teams were blocked, calls weren't going through correctly, and the one person with the most authority in the room was actively working against the patient. That's what happens, and that's what trapped means in a hospital under conditions like this. Not chains, not locked cages. Process, access, hierarchy, and delay. A month later, I learned something else. The man security thought they were looking for in the stairwell. The reason they locked vertical movement was never identified. The camera image they circulated was grainy and partial. Maybe a visitor, maybe a staff person in a jacket, maybe no one relevant at all. Security later admitted the lockdown may have been triggered on incomplete information. So Denise may have died on a sealed floor because one possible sighting turned into a system-wide restriction at exactly the hour her doctor needed time and privacy most. That part was never included in the final review. I left Northview about 8 months later. Tasha left before I did. Mateo transferred to outpatient records. Last I heard, Keller was practicing in another state under supervision, though I don't know if that's still true. What I do know is this. I still keep that screenshot. It's time-stamped 12:06 a.m. You can see Keller's note where he wrote that the patient was stable, responsive, and appropriate for continued step-down monitoring. 14 minutes later, we were doing compressions. 41 minutes later, she was dead. And by the time we proved the doctor was lying, the doors were locked, the help was cut off, and the only person in that room who still had any control over the story was the one who was trying to bury her with it.